No? I will post it. I can post it, JJ. If
No,
David...
no, I'm here, Hala. Go.
David, on the tendon and ligament, we are developing materials here, which I'll talk about in my session. The question to you, what is it really critical that the material is degradable? Because we're having problems attending to only this one. We've ticked all the boxes except for this one.
So you're having problems with which
developing
box?
a material that is degradable. How important is it that the synthetic material, if we have one for you, would you then tell us, would this material degrade, or would you
Preferably not.
Preferably, really?
Yeah. I mean, because the meniscus is a structure that you'd like to last for the duration of a person's life. I mean, a little bit like the intervertebral disc, right? So we all, as we mature, the integrity of the disc declines over time, but in an ideal world, it wouldn't.
What about ligament and tendon?
For ligament and tendon, I don't know if Dave Parker's there, but again, I guess my perspective on ligament and tendon is if it can retain some of its mechanical integrity over time to allow cellular ingrowth, I think that's actually fine.
Thank you. Thank you very much. Very important. Thank you.
Yeah. I mean, again, I think it'd be good to have Dave Parker or someone else's perspective on the ligament and tendon piece. But I think one of the challenges that historically has been faced is that it loses some of that mechanical integrity too quickly, and as potentially the consequence fails.
Okay. I think we can post that question for whoever can answer it later, yeah, if you want David to also contribute to it.
Yes, I believe David Parker is an apology for the Q&A session, so okay. we'll post that question onto him. So there was a question for Professor Nanganathan with regards to real-time monitoring. So is that something to facilitate better understanding of the precipitating factors, or is the concept that those, because there's real-time monitoring, the precipitating factors can be used to do alerts in real time, that is? Apologies, gonna ask, we'll unmute all of the speakers so that they can answer questions.
Yep. So could you just, so the question was, could you just say that last bit again? Sorry.
Sure. So the purpose of the real-time monitoring, is it just to understand the precipitating factors or to alert when the risk factors are increasing so that patients can be, supported if they're at risk of falls?
Bit of both, probably more the former, to really work out why someone has fallen or why they're falling. So if I take the example of the cardiac monitoring, sometimes it's really difficult from the history or the story from the patient to work out whether this might be a cardiac cause. And I've seen patients who've had pacemakers put in that hasn't fixed the problem because the assumption quite correctly has been made, well, they've got a cardiac abnormality, they're falling, there's a decent probability that they're related, so we'll put in the pacemaker, but knowing that that won't guarantee. If you actually had it real-time monitoring, as in, here's the cardiac abnormality, and that's when they fell, and that's when their blood pressure dropped, you're much more confident, therefore, that putting in the pacemaker and the right kind of pacemaker will decrease the probability of falling. So it's more for that immediate correlation between those three things.
Great, thank you so much. I believe Craig had a question for David Hunter.
Yeah, David, I was just wondering what engagement you had with bioreactors for the meniscus, because obviously recreating the architecture and the biomechanics of the tissue is very important, particularly in a hyaline articular cartilage. Trying to recreate that zonal architecture is a real challenge. Just wondering if you've had any experience with that.
In short, no, Craig. I mean, I think it's an area where there's a lot of groups doing quite a bit of work, but at this point in time, nothing has really got to a point where it's being widely or readily used clinically, primarily because it doesn't recreate that architecture. Because it, you know, I think potentially because it needs to be somewhat personalized to the anatomy of that particular individual and configured in a way that adapts to where the roots should be inserted as well.
And what the directions of force, yeah.
Yeah.
There is a question from Rory for Vasi. Do most falls in the elderly occur in or outside of the home? And does this change your approach to designing technology for falls detection?
Good question, Rory. I don't know if you took all older people above a certain age, the answer to that question. I know that, I guess this is obvious perhaps, that in frailer people, it's more likely at home, and more active people, obviously more likely out of home. So there's good data about, if you like, the level of frailty and where people fall. So frail people more likely to fall at home. And the second part of the question, Rory, was, does that influence where you might do monitoring? So at the moment, my understanding of the technology is that overall home monitoring and visual monitoring is easier when people are at home, whereas out of home, really you're relying on wearable technology. And the problem with wearable technology is that the algorithms are still too imprecise for it to be able to be used widely out of home. So at home allows you to use both forms of technology, the environment sensors, as they call them, and wearable technology. Outside home, you're pretty much limited to wearable technology, but they've got their limitations at the moment in terms of widespread use. And the third part of the question, or the question you asked, was, do falls that result in injury occur mainly in and out of home? Don't know the answer to that one. I wonder if Lynn knows the answer to that one. It's a good question.
Unmute myself.
Yep.
I think they're more injurious out of home because it's the more active people, and then so I think the falls that occur out of home, is that what you're asking? So that they yeah they're more, the fall is more likely to result in an injury if it's out of home, but that's also a function of the type of fall that people are having and the more active people. Yeah.
So there's a question in chat, which is for all of our speakers. A lot of work is done based on the assumption that patients want pain relief. That is, they have score 10 or no pain at all and feel comfortable. What if they actually need is 8 or 7 so that their body can adapt or evolve? Mainly because evolution happens in a stressful environment or when there is a need for it. Any thoughts? So hang on, we'll need to unmute a couple of our speakers.
Yeah, Munir, it's a good question, and it's something we're deliberating quite a lot at the moment, in part because of this concept, and I'm not sure whether this is the direction your question's going in, but this concept of analgesic arthropathy, so that if we potentially relieve too much pain, they lose some of their mechanoception and their ability to actually interpret injurious load as well as normal physiologic load. And I think for some of the adaptations we're talking about today, potentially some of the and a wonderful bioengineer and that we do some work with St. Louis and Washington is doing some work around looking at incorporating mechanosensors and calcium sense and ion channels into his scaffolds and bioconstructs so that they are actually sensitive to load, as opposed to completely ameliorating any sensation at all. And again, if I'm misinterpreting your question, Mania, please just let us know, or just walk in my door and yell at me.
I might pick up on a little bit of that as if we're sort of thinking, well, maybe we're over treating because an extension to that. But we do know, and could the body adapt by evolution? But so far, what we know about people persisting in pain, to me, it's not healthy to stay in pain. Basically, pain puts up your blood pressure, increases risk of cardiovascular disease, poor sleep, lowers your immune system. So there's quite a lot of reasons to, maybe not totally get rid of people's pain altogether, but certainly to have much lower pain levels than the 8 to 7 that you think maybe we could adapt to. And people with arthritis do adapt to it. They're incredibly resilient, and so they say they do put up with it. But a lot of quite good evidence that it's unhealthy for the body generally, and metabolism and all the immune system and all the other things that are going on if you have persistent pain.
Len, I'll follow up with that. I imagine a lot of adaptation to pain is actually maladaptive. So if you're in pain and you're protecting a painful joint, then it leads to functional alterations that are not beneficial in the longer term.
Yeah, that's a good point, Rory. Like a lot of people, it's sort of their inactivity and then their secondary diabetes, type 2 diabetes, obesity. Even in some of the elderly, there's some work looking at one of the reasons that elderly don't walk or do things is because of pain. It's one of their key things. And then it's quite linked to cognitive decline. And so it's the mobility is the important bit, but you need to get rid of pain so people are more mobile.
I was going to say that I've learnt this from the pain group at North Shore, that they've shown that you can have healthy adaptation using, I guess, two main bodies, a psychological approach as well as a functional approach, that is, setting goals for function. So I think that, they've done really good work to show how you can get functional and healthy adaptation as opposed to unhealthy adaptation or maladaptation. So there's whole science behind that, both at a biological level and a clinical trial level and psychological level.
Okay, thank you all to the speakers. There is just one last comment/question from Thomas, and then I think we need to wrap up the rest of this session. So there certainly is a lot of discussion from anesthetic and pain specialties to do with redefining pain response to bring people to an acceptable level of pain rather than no pain at all to avoid over-treating. I guess this is more of a comment, but if any of the speakers want to respond to that, and we may have to wrap up after this.
No, we agree with that.
All right. I believe that's the end of this first session that we've had. I hope you all had and enjoyed the session, the talks. Thank you to all of our speakers. It was certainly an eye-opening experience. We are now going to take about a 10-minute break, get some tea and coffee, and we'll be back for the other session at 3 o'clock. So see you all in 10 minutes.